Good afternoon, everyone, and welcome to Scottish Drugs Forum's third and final winter webinar. Uh, my name is Andrew Macaulay, and I'm a professor in public health at Glasgow Caledonian University, and I've got the honour of chairing today's event. Now, today's topic has generated a huge amount of interest. It's fully subscribed, so thanks everybody for showing so much interest in this important topic. And the topic is the use of stimulants, which has emerged, particularly in recent years in Scotland, to a situation where now the majority of people presenting to drug treatment in Scotland say their primary drug of use is cocaine. So we're going to focus on that subject today. We'll have three speakers today, and at the end we'll have some time for questions and discussion after we've completed the presentations. So I would encourage you to post any questions you might have in the Q&A section in the chat, which you can access at the bottom of the Zoom window. And just to let you know that the webinar will run to 2:15 p.m. at the latest. We won't go a second beyond 2:15. We've got three presentations today, and then we'll come back together after that for the Q&A session. The format of today is that I'll open things up with just a general overview of the situation at a Scotland level, really just setting the scene and contextualising things before we get a bit more in-depth insight from John Campbell from NHS Greater Glasgow and Clyde. And then John will be followed by Magdalena Harris, who is a professor from the London School of Hygiene and Tropical Medicine. So delighted to have both John and Magdalena join the session today. So without further ado, I will get cracking with the first set of slides. Okay, so I'm going to give you an overview of current trends, harms and responses in Scotland before we move on to presentations from John and Magdalena. So, if we start on trends in Scotland, and just to highlight today, we're not just going to be, a lot of the chat in Scotland has been about powder cocaine in recent years, but we're going to be covering both powder cocaine, so cocaine hydrochloride, but we're also going to be covering crack cocaine today as well, which has been emerging as a big issue in recent years as well. So just to clarify that at the beginning. Now, data on stimulants and cocaine is perhaps not quite as straightforward as data on maybe other drugs of dependence, particularly opioids, which have been the focus of much attention in Scotland for the last 30 or 40 years. And that's something we'll maybe highlight over the course of today's presentation. But we look at a population level, we're really restricted to things like population level surveys. And what we see from the population level surveys is that around 1 in 10 adults report illicit drug use in the last year. We know that trends for illicit drug use self-report are increasing, with higher rates in men, the under 25s, and in the most deprived areas. And in those population level surveys, those general population level surveys, the most common drugs reported are cannabis and cocaine. But we know in those general population surveys, they're likely to exclude people who have a high risk use of substances or people with dependence issues on substances. So that's where we need to look at other methods, and particularly for kind of more common drugs of dependence, or what we crudely call in Scotland problematic drug use, the focus over the last 20 or 30 years has been on benzodiazepines and opioids, and we get these prevalence studies that typically published by Public Health Scotland or ISD in the past, and the estimate has generally been around 60,000 people with problematic drug use in Scotland using benzos or opioids, and that's held fairly stable over the years in which those studies have been conducted. The estimates of prevalence of people who inject drugs are not as recent and are due to be updated shortly, and they generally estimate about 15 to 20,000 people inject drugs in Scotland. But like I say, the focus of a lot of these studies has been on benzodiazepines and opioids, not on stimulants and cocaine. So that leads us to look at other sources. So one of the best sources we've got at a national level to look at changing trends of cocaine use is the Needle Exchange Surveillance Initiative, or more commonly known as the NESI study. So this is a biobehavioural surveillance initiative that goes on every couple of years across mainland Scotland, where it interviews people who inject drugs, a representative sample of them, and takes a right blood spot sample to monitor things like prevalence of bloodborne viruses. But a whole host of other information is generated there, including the type of drugs people are using. And you can see quite clearly through the NESI studies that the injection of cocaine, and by cocaine here we mean powder cocaine, which is in the orange bar there, you can see that's really rapidly increased over the last decade or so. Really, NESI started to pick up this increase from around 2015, and in the most recent NESI surveys that were completed in 2023, you can see prevalence nationally hitting about 60%. But we know if we look more forensically at different areas of NESI, so Glasgow city centre, for example, there were higher prevalence reporting of cocaine injecting than there was of heroin injecting for the first time in the most recent survey, which is a fairly symbolic event. You can also see here, probably not quite as clearly, but in the kind of ambery yellow bars here, we're also picking up crack here as well, and an increase in crack, and that went above the 10% mark in the most recent survey for the first time. So a clear kind of changing trend in the type of drugs that people are injecting. And it's not just NESI that shows this. This was a study that was conducted, a kind of European level study back in 2017. And this looked actually at discarded syringes. It was a residue based study, so testing the residue left in discarded syringes. And it compared 6 or 7 different cities across Europe at that time. And you can see actually back in 2017, even when we were having this seminar in 2025 to highlight this big issue about cocaine, but back in 2017 it was already an issue. You can see Glasgow, they are coming out with the highest prevalence of cocaine detected in those syringe residues at that time compared to other cities across Europe. So cocaine injecting matters for a whole host of reasons, but some of the main reasons why it's important is, first of all, it increases polydrug toxicity. People are generally not injecting cocaine in isolation. They're injecting cocaine alongside injection of other drugs, alongside consumption of other drugs, whether it be opioids, whether it be benzodiazepines, whether it be gabapentinoids, whether it be alcohol. It's generally part of a polydrug toxic mix that street drugs feature in Scotland. Also, because of the nature of cocaine injecting, it's known to increase people's risk of infection because it's associated with a higher frequency of injecting because it has a shorter half-life than drugs like heroin, for example. And that higher frequency increases people's risk of sharing and people's risk of reuse, which are all associated with an increased risk of infection. It also increases one's libido as well. So if there are any sexually transmitted infections in networks at the time where cocaine has been injected, then there's potential for cocaine to be associated with sexual transmitted infection. We know that was a feature of the HIV outbreak in Glasgow recently, which we'll touch on later. And then there's also evidence to show that it impacts treatment outcomes. So, for example, a lot of people who have co-occurring opioid and cocaine dependence, there's evidence to show that retention and engagement with opioid agonist treatment, for example, is impacted by cocaine injecting because of the frequency associated with it. Now, as I said, it's not just injecting, so NESI has evolved a bit in recent years to look at drugs that are smoke, snorted or ingested. Very quite crude terms, but important to monitor this as we've seen drug use evolve in Scotland. And you can see here clear evidence that we are now seeing not just a shift in cocaine injecting, but also a shift in smoking of cocaine, particularly crack here, which again, the other guys will touch on in more detail. In terms of harms, well, as you might expect when people engage in this high-risk drug use, then harms are associated with it. This is self-report data from NESI again, which shows that those who'd injected cocaine had higher rates of skin and soft tissue infection. This is self-reported skin and soft tissue infection. Interestingly, those higher rates were visible even back in 2013-14, but they've maintained at a higher level in comparison to people who don't inject cocaine. Similarly for non-fatal overdose rates in the past 12 months are higher amongst people who inject cocaine. And this, perhaps these kind of harm indicators are then playing out to what we see in secondary care or in hospitalisations. And this is quite a busy slide with a lot of different drugs on it. But the one to look out for here is the kind of grey line, which is really emerging from, again, around 2015. Very synonymous with that onset of cocaine injecting. And you can see this green line starting to increase towards the onset of the pandemic there. So drug-related stays in hospital involving cocaine have really started to increase from about 2015. And similarly, drug-related admissions related to overdose, so taking that a bit more granular. So the drug-related stays increasing, but the overdose-related stays related to cocaine correlate very strongly. So there's a very parallel trend there. You see it again going up from about 2015 onwards. So what we're seeing in the community level is now playing into the secondary care level. Interestingly, cocaine-related deaths, as you might expect, well, if you're seeing hospitalisations going up, then morbidity often informs mortality, and we see cocaine-related deaths have rapidly increased. And again, this kind of key trigger point from about 2015 onwards, and there's actually been a 13-fold increase in cocaine-related deaths since 2008. So this has all been occurring at a time where a lot of the focus has been on benzodiazepines, rightly so, because it was also hugely increased over that time, and also other opioid type drugs, including more recently the synthetics. But cocaine has been this kind of elephant in the room in the background that's just continued to increase, while a lot of the attention's been focused on other substances. And this image, this is something developed by a colleague of ours, Joe Schofield. I think this just really illustrates cocaine's role in the kind of polydrug combinations that people are involved in. So this is related to drug-related deaths, and you can see in the far left in 2008, basically the thicker the line, the more likely that people are to have both substances involved in their toxicology. And you can see there's a couple of thick lines really emerging back in 2008, opioids and alcohol, opioids and benzodiazepines, and a few thinner lines there. But when we move across to 2020, much more thicker lines representing a much more varied and complex range of polydrug use among individuals. And you can see cocaine really emerging as a feature in those kind of thicker line combinations, highlighting its role in polydrug use in Scotland. So is cocaine injecting driving mortality? This isn't scientific by any means. This is me being very blunt and crude, just posting for discussion really only. But you see the rise in cocaine-related deaths is very parallel to the rise in cocaine injecting. So potentially a hypothesis there worth exploring. In terms of other harms, it's important to highlight HIV amongst people who inject drugs. Obviously, prior to the last decade, HIV among people who inject drugs was largely a historical issue in the UK, confined to the major outbreaks in the 1980s, particularly in Scotland and places like Edinburgh and Dundee. But of course, that was brought under control thanks to interventions such as needle and syringe provision and opioid agonist therapy. But then in Glasgow in 2015, we've seen a re-emergence of this when we identified around 50 cases, 50 new diagnoses of HIV in 2015. And if you trace this graph goes all the way back to the early 1980s, you can see that was the highest number of new diagnoses in Glasgow since that decade. So a fairly important event that merited significant attention and response. And the data we had, again, this is NESI data, shows that the impact of that outbreak and prevalence in Glasgow city centre increased tenfold in a very short space of time. So this was a major re-emergence of HIV in this population that we hadn't seen for such a long time. And the reason I'm highlighting that is that when we did the modelling work for this, the strongest driver or the strongest predictor of cocaine infection amongst people who inject drugs in Glasgow was cocaine injecting, associated with an almost sevenfold increase odds of cocaine of HIV infection amongst those who injected cocaine compared to those who didn't. So a very key feature. And again, this is data pulled from 2015 to 2018, so this isn't recent. This has been an issue for some time. And obviously not all to highlight that this is about Glasgow. I've showed the NESI data at a national level, but this is also more focused work that was done in Edinburgh. It was the needs assessment work for the drug consumption room there. And a lot of the qualitative feedback we had from participants in that study was highlighting the need to address cocaine. So I've just highlighted that in this initial overview to flag that this isn't just a Glasgow or a West of Scotland issue. This is now very much a Scotland level issue that people are dealing with, both people who use drugs but also people responded to that through services. And that gets us to responses, which I'll finish on here. So we've highlighted that the majority of people attending treatment now are attending for cocaine. You can see that in some of the Public Health Scotland data here, this big jump in the data here. And it's worth just looking at the evidence base in terms of what it says about how we respond to cocaine dependence. And very much in contrast to what you see for opioid dependence, for example, where there's a very clear pathway and clear options for responding to opioid dependence, whether it be pharmaceutically or pharmacologically. It's not as clear cut for cocaine. This is the MCDDA review, which talks about a mixed picture emerging from the evidence, but highlighting where the evidence is strongest, and that's really around psychosocial interventions, uh, and contingency management, which is effectively incentivizing people to take part in treatment. It says suitable medication, but there isn't necessarily an immediate go-to medication for cocaine dependence in the UK at the moment. Certainly not people with both co-occurring opioid and cocaine dependence. The Orange Guidelines just reaffirm what you see at a European level, highlighting potential for psychosocial interventions here, calling them the mainstay of treatment for the misuse of cocaine, and highlighting the limitations of the pharmacological and the pharmaceutical interventions that have been tried thus far. Some local areas have developed their own toolkits to get around that. This is just an example of one from Glasgow. I'm sure there are many others. And there's also e-learning from Scottish Drugs Forum that people can access. But that's not prevented people globally from trying different things, as is the way with science. People are trialing different approaches, and this is just an example from the Netherlands where the use of dexamphetamine was trialled within their heroin-assisted treatment clinic there. So that's for people with co-occurring opioid and cocaine dependence. So that's a potential thing that we could potentially consider in UK as we see more and more people facing similar issues. And then just to highlight the research community, I think has been a bit slow to respond to this, but we're now seeing some tangible examples where there are funding routes available for these specific issues. This is one that would come out from the Invention for Innovation, the I4I Addiction Mission, so not to be confused with our Addiction National Mission in Scotland. This is the one in England where there was a funding call last year, and there are now active projects looking to address cocaine dependence amongst people in drugs. And then just to finish off on harm reduction, I think this slide, I'm always a bit caught in two minds with this slide because it does look as if harm reduction is brilliant for cocaine and we've kind of got it all sorted with the odd exception. And I don't think that's necessarily what I want to convey. What I want to convey here is that there are options out there. So from left to right in the top row, we have needle and syringe provision, we have bloodborne virus testing, we have naloxone, which is important if people are using more than just cocaine. We have free to access condoms to address the sexually transmitted infection risk. We have PrEP available for people who inject drugs in some parts of the country. And then we have recently opened the Safer Drug Consumption Facility in Glasgow, the Thistle. And data is already emerging from that the overwhelming majority of people using that service are using it for cocaine injection. We don't, in the middle, have our drug checking services yet. They seem to be bogged down in a lot of red tape at the moment. I think it's hoped that they'll be delivered soon. But again, they'll be important services for people who use cocaine. And soon, and we'll certainly touch upon that in the next couple of talks, we hope to have provision of inhalation equipment from our services to address the increased number of people inhaling cocaine or smoking cocaine in our communities. The key thing just to flag about the drug consumption, which I probably should have mentioned there, is although the majority of people are using it to inject cocaine, of course people are not allowed to smoke substances on that site. And sorry, this just highlights that point I was making about the Thistle. We've only got very early data from that, but I don't know if people are surprised at this or not, but almost 90% of the first tranche of people using that injecting cocaine. We expected cocaine to be in the majority, but maybe not quite that significant a majority. And I think this is again highlighted this is such a major issue for everybody to deal with, and that's why perhaps this seminar has attracted so much attention today. Okay, so just to summarise before I bring in the other guys, what I'm trying to convey here from a contextual point of view is that cocaine use is now endemic in Scotland. It's endemic, it's moved away from the recreational kind of nightlife scene to very much the street, community level drug scene, which we're all now increasingly familiar with. And that the harms associated with are increasing and are complex. It's not just a bloodborne virus issue or an overdose issue. There's many other infections and mental health related issues associated with this. And certainly, I think we could all agree that the current responses are insufficient to meet the demand we now have for cocaine. And I think part of the reason today is Scotland needs to be bold and innovative to reduce cocaine-related harms, and hopefully today can help springboard that response. So I will end my slideshow there. And as I said, I think questions and answers can be done in the chat at the side, or we'll cover that at the end. But I'd like to now bring in John Campbell from NHS Greater Glasgow and Clyde to deliver his talk. Thanks, John.
That's lovely. Thanks for that, Andy. So essentially what I would like to do, following on from Andy, is almost take a historical look at the emergence of cocaine. And by historical, I mean over the past 10 to 15 years. And I want to look at how well we've responded within that period, and potentially if there had been missed opportunities for us. So as Andy highlighted, we maybe don't have such a good grasp in the scale and nature of all types of cocaine use as we would like. I'm not even sure, for example, if we're able to say how many individuals that are currently engaging with our services are smoking crack cocaine, or how many many individuals engaging with our services are currently injecting cocaine. Of course, when you then start to look at the populations who are snorting cocaine, then it becomes much wider within society as well. But even the basics of what you would expect us to have a real grasp on, I'm not so sure we do. And I think that's reflected in the way we report it. Quite often we hear people saying, yeah, we're seeing quite a big increase in the amount of people smoking crack cocaine. Or they'll talk about, yeah, there's a lot of harms associated with the smoking of crack cocaine. We're definitely seeing them, but nothing is properly recorded and reported. And as I talk about Zumutha at this presentation, I think that could really be holding us back. Even when we look at IEP data, that transactional data, then because the emergence of cocaine has really been initially from individuals who were mainly injecting heroin, then to injecting heroin and cocaine, possibly just moving to cocaine only. But when they registered on the Neo 360 database, they gave their primary drug of injection as heroin. And unless someone's actually went in, a member of staff has went in and updated all that information, that's still going to be registered as that individual is injecting heroin, but they may not have for the past 4 or 5 years as they're injecting cocaine. So we need to look at that data cautiously as well. And even when we look at toxicology, then, yeah, it's really interesting to see that, cocaine has been picked up so frequently in drug-related deaths. But we're maybe not even sure of the full mechanism of death, cocaine's role in the mechanism of death. And although it's been picked up in the system, we're still unsure of the method of administration as well. So for some of the data that I'll share with you through the WAND initiative, and Andy has already shared through Needle Exchange Surveillance Initiative, this is good, solid, robust data. However, the massive caveat there is it's only within people who inject drugs. So taking a look back at potential missed opportunities, in 2011, we commissioned the Scottish Drugs Forum to conduct a fairly large customer satisfaction survey. It was actually a fascinating piece of work because it involved kind of 60-odd client interviews, but also involved us recruiting people who were currently injecting drugs to go into 16 of our IEPs and conduct a mystery shopping type exercise, and obviously feedback to their experience. But what had came back is for these 60 interviews that they had did with clients, 95% of them were injecting heroin. 40% were injecting cocaine. However, the majority of individuals that were injecting cocaine were also injecting heroin. So that did raise our eyebrows. But then we went, right, okay, so let's look at those that are injecting heroin. Well, they're really likely to be engaged with treatment and likely to be receiving some form of ORT. So that by default means that those people that's injecting cocaine are already engaged with treatment services. And I think, certainly from my perspective, this was our first real missed opportunity, almost to look at that as a population, those injecting cocaine as a population in their own right. With outbreak HIV in 2015, and we were aware almost immediately from that outbreak, you know, from the equipment people were taken away, or from the very in-depth interviews that we conducted with people who had recently contracted HIV, that cocaine was a massive driver in relation to the frequency and high risk injecting practices. Well, that was also highlighted in the large health needs assessment we conducted the year after that, called Taking Away the Chaos. So taking away the chaos highlighted that cocaine was a massive driver for the transmission of HIV, as well as another whole series of health implications. Now, Taking Away the Chaos made a series of recommendations. Two I'm sure everybody here will be familiar with. One was the introduction of a safer drug consumption facility. The other one was the introduction of heroin-assisted treatment, or in Glasgow it's diamorphine-assisted treatment. A series of other recommendations that were about improving access to the provision of injecting equipment, understanding more about public injecting, or we would term it now away from home, or outdoor injecting, more about services working better together. None of those recommendations in any way were aimed solely at the injection of cocaine. Now, none of those recommendations, for example, were to do with route transition. And by this point, we had good evidence that the provision of foil was well accepted, and the uptake was strong amongst our populations as well. 2017, we started the planning for the safer drug consumption facility. And at that time, we did discuss the potential for that to include an inhalation room. But it was felt at that time that due to things like smoking regulations and the cost of installing extraction equipment, actually stopped us progressing with that. Of course, even in 2017, I don't think we had any idea just how many individuals we would have now smoking crack at a free-base cocaine. Later that year, the prevention leads linked in with the Scottish Government, and through that the Crown Office, to in an attempt to try and provide inhalation devices, and that's a request that's still progressing to this day. So I think when you look back over the past 14 years, we've had a number of key opportunities to try and raise cocaine injection or the smoking of crack a free base as an issue, and at least start to plan to respond to that. But we'll look at IEP data. Now, again, even looking at this over a kind of 5 or 6 year period, obviously that was affected by the pandemic. So the red cross here is just indicative of the start of the pandemic. Now, towards the end of the pandemic, when we look at the figures, there was a real reduction in the number of transactions and also the number of clients that were accessing IEP. So 44% reduction in transactions and a 38% reduction in clients. And to this day, no one really knows where that population had went. However, this was a time that cocaine injection, and it now appears the smoking of crack cocaine, was becoming far more prevalent. So I think it's safe to assume at least some of those clients moved away from injection, even injecting a cocaine, to the smoking of crack or freebase. And when we look at the equipment that was given out over that time period as well, then of course we noticed big reductions. But interestingly, we didn't notice the same reduction in the number of sheets of foil going out as we did with needles. Now, bearing in mind, we'd expected more needles to go out because people were injecting cocaine and potentially more frequently there as well. So this, I guess, highlights for us that this route transition intervention that we promoted from 2015 on was widely accepted and wasn't affected in the same way as injecting equipment coming out of the pandemic. So in 2020, we introduced WAND. That's Glasgow's largest ever coordinated harm reduction drive. And within a year, we had completed 1,256 WANDs. So here I've just done a comparison between the data collated in 2020 and to the last reporting year for WAND. So we look at the increase in cocaine injecting. It's jumped from 64% up to 82%. When we look at the smoking of crack cocaine, of freebase cocaine, this is the largest percentage jump from 12% up to 38%. And the largest percentage reduction is actually in heroin injecting. So I had fallen from 74% in the first year to 56% last year, and also a reduction in the use of benzodiazepines. But to get this bang up to date, I've pulled the data and looking at the last 6 or 7 weeks. So for the 1st of January to the 19th of February this year. And I've looked at the WAN data, not just from Glasgow city centre, but also on the periphery of the city centre and other parts of Greater Glasgow and Clyde, where they're all pretty much mirroring what's happening. And we can now see that 86% individuals that access WAND were injecting cocaine. 56% reported the smoking of crack cocaine, and only 46% reported the injection of heroin. So that's really quite dramatic, even in that short period of time. Okay, so to bring this to a conclusion, I think we really need a better understanding of all cocaine populations. And for us as a field, if we want to target specific populations within that, we need to decide what that target population should be. For example, are we going to target people who inject cocaine? Are we going to target people who smoke crack cocaine or freebase cocaine? Or is it both those groups joined together? Or are we looking for something wider relating to all methods of administration for cocaine? Now, the one data does show a population that inject either heroin and cocaine, but also smoke crack or freebase cocaine, but that doesn't in any way pick up that population that only smoke crack or freebase cocaine. In a positive note, our IEP data since 2015, so we've got a decade now, that shows that the provision of foil is very well accepted and very well used within the population as well. In fact, even from a Glasgow perspective, last year we provided 400,000 sheets of foil. And I think that provides foundations at this point to allow for the introduction of inhalation devices. Okay, I'll stop sharing. Thank you.
Thanks, John. That was great. And your point there about inhalation devices links in very nicely to our next speaker. So before I bring in Magdalena Harris, just encourage people, if you do have any questions you would like answered at the end, please do post them in the Q&A section that you can find at the bottom of your screen. So over to you, Magdalena.
Thanks, Andy. Thanks, John. Yes, it's a very good introduction to my little presentation. So I'm here to talk about the Safe Inhalation Pipe Provision study. So you guys don't really need this introduction, but just to flag that I'm going to be talking about the English context, and there are some parallels. It's particularly interesting to hear John talk about the increase in crack cocaine use and in terms of crack smoking, which is what I'm going to concentrate on. Crack smoking is really common in England, but also throughout the UK. Unlike heroin, we don't have any agonist pharmacotherapy options licensed for stimulant dependency. I do have some thoughts about that, which I could talk about in the chat later if people are interested. But I think importantly, and what I'm going to focus on here, is that unlike injection drug use, we cannot provide equipment for stimulant inhalation. We can provide foil, but that's not fit for purpose. Particularly for people who smoke crack or people who smoke methamphetamine, which is another population which are currently not accessing drug treatment services. And from my perspective, there really is very little harm reduction supports for people who use crack cocaine, and particularly people who smoke crack. There's very little reason for them to engage with drug treatment services. And so this is where the study came about, really, is that we wanted to understand whether equipment provision for crack smoking had benefit in the English context, and if it did, if there was potentially a case, therefore, for legislative review. As you can see here, the Misuse of Drugs Act 1971, Section 9A, equipment must be listed as an exempt in order to provide it legally. So most injecting equipment is exempt. Foil was included in 2014 after a lengthy advocacy process, but stimulant inhalation pipes are not exempt, which means that providers are liable for prosecution. So the aim of the study, and this is run by London School of Hygiene and Tropical Medicine. I'm the PI with lots of wonderful collaborators, including peers and drug treatment service providers. And the aim of the study is to evaluate a safe crack inhalation intervention distributed to people who use crack via drug treatment services, outreach and peer networks in order to reduce crack-related health harms and inform legislative review. So we're quite explicit about this desire to actually look at changing the law if the evidence warrants it. The methods, we have an impact evaluation, which is a before and after survey. You can see the little diagram there. Also qualitative interviews, observations, and monitoring data for a process evaluation. I'm going to walk you through some of the initial findings. And just to point the outcome measure. So the little diagram illustrates that we have a pre-survey, then we have the intervention. We pre-survey for about up to 3 months, the intervention for 6 months, and then a follow-on survey. And the outcome measures are assessed through measuring the differences between the before and the after. And we also have control groups so that any sort of differences throughout the country, for example, to drug markets, are taken into account of and not attributed to the intervention when they shouldn't be. The outcome measures relate to hepatitis C risk reduction, but what I really want to focus on here is respiratory risk reduction. I think this has been massively overlooked within drug treatment services, and there's a real issue that we need to now engage with. So our primary outcome measure is reduced pipe sharing. We're also interested in seeing if the intervention will impact injecting practice, acute cuts and burns, drug treatment service engagement. We want to see a reduction in homemade pipe use, ASH, which I can explain what I'm talking about there, and reduced respiratory risk markers. And we did this through getting local police letters of comfort because, of course, it's an illegal intervention. So that was another story in itself. And if you want some more information, there are some links there at the bottom. So thank you to Exchange Supplies for providing the intervention materials. And I really want to stress that this is not just equipment only, not just a pipes only intervention, but that we also developed an online training module for providers to skill them up and how to talk to people who use crack, how to understand what, the mechanisms of using crack, what's important to people who use crack, understand what things like recycle are and stuff, which I can also explain, which I think is really important to think about in terms of the intervention, that it's not just about providing the equipment, but enabling providers to have better conversations and engage with this population. All right, so I'm going to refer to our baseline survey findings. And, I just want to thank everyone who's been involved in this study, because it's been incredible that we have achieved really what we set out to achieve, and that we, the baseline survey, we reached our target sample, which is just over 700 people, and that has been matched by the follow-up survey about an equal amount of people with some crossover. And this is, I think, a really unique cohort, which we don't know much about and that we haven't really captured in other sort of surveys. As alluded to in the previous presentations, most of the surveys are carried out through with people who inject drugs, who are recruited through needle and syringe practices, for example. But what's really of note in this population is that we have let's see, we have about 60% of people reporting not injecting drugs in the past month. So yeah, so 66.2% of people report that they didn't inject drugs, they just smoked only. And this is a dedicated population of people who use crack, with just over 55% of people reporting using crack every day. The duration of crack use, or at least the amount of years since people initiated crack use, is high. You have a median of 21 years that people have been engaged in crack smoking or on and off crack smoking. And of note is that 10% of the population reported having smoking or having breaks from smoking from between 31 and 40 years. There's been mention of polydrug use. You can see that people have a load of sedatives on board. There's a lot of benzos there. Nearly 30% of people using benzos. Not surprising that there's a lot of people using heroin. Heroin and crack or cocaine go very well hand in hand. Also of note is high use of pregabalin at 40% and spice at 25%. We had just about nearly a third of women in the baseline survey, which was really great, and a reasonable proportion of people who are street homeless and unstable, and we had 38% of people reporting not being on opiate substitution therapy. We were interested in respiratory harms, and we also asked about symptoms that people would attribute to crack use in the last 28 days. So asking about mental health issues, acute cuts and burns, because they can impact hepatitis C virus transmission of people sharing pipes, for example. And so, we had just over 80% of all participants reporting at least one crack-related symptom, a symptom that they attributed to their crack use, including 57% reporting anxiety, there's paranoia. But what I really want to highlight and what I'm interested in exploring, and I'd really invite people to email me, get in touch if you have any ideas about this, is the gender disparity in reported respiratory symptoms, diagnoses, and hospitalizations. So we had a high proportion of people reporting any respiratory symptom, but this is a marked difference. You had 59% of women reporting as opposed to 48% of men. If you look at breathing problems alone, you have 53% of women reporting breathing problems as opposed to 40% of men. 36% of women were reported asthma diagnoses, opposed to 28% of men, COP, 15% women. And also I just think it's extraordinary that nearly a quarter of the women reported being hospitalized for pneumonia, and that is also in contrast with 14% of men. So you could just see that this came through symptoms to diagnoses to hospitalizations as gender disparity. Now, of course, if something is not provided, it doesn't mean that people aren't doing it. So, we tried to get a sort of overall letter of comfort to allow for pipe provision during COVID, because we were worried about people with high respiratory risk sharing pipes. We just thought this is a recipe for disaster. And the answer came back from the Home Office that no, it would encourage crack use, which I don't agree with. And I think people who want to use crack are already using crack, as we can see. They're just not doing it in a particularly safe way. And here are some examples of the types of pipes that people are making and some of the ways in which they can cause harm. So inhalers is a really sort of visceral example, really, in terms of, and I guess this is part of the training and thinking about how do you understand what's going on for people who use crack, how do you talk to them, understanding the value of things like recycle. And so if you're smoking crack, the crack will adhere inside the pipe. There's a crack residue that would adhere and it's quite strong, so people will scrape it out and smoke it again. They call that recycle because it can be recycled. So here with the inhalers, I heard this over and over again. This participant says, we're scraping it with a knife, and where they've scraped so hard, there are blue curly bits from the inhaler plastic in. You can smell it when they burn it. It's just like smoking plastic. So people are scraping out the recycle, and they're also getting bits of plastic out with that. Then they are smoking that again. So that's obviously going to be a respiratory harm with those plastic fumes being inhaled. A lot of people transition to use of small cannabis pipes. Now, you might think that these are much better, but the issue with these is that they are short. People often might take off the top, so they just have a very short bolt, and they get really hot. So people are then inhaling a very hot vapor, and people talk about, as this person says, it burns your lips and burns your tongue. But what people may not also realize is that they're inhaling the very hot vapor, and then that's damaging their lungs. And cocaine has a numbing effect, so they may not be feeling it at that point. In order to smoke crack, you have to have a suspension device, if you like. It's not really a filter, it doesn't filter anything, but you need something for the crack, once it's heated, to soak into, and then it's heated again and it vaporizes. So it needs to be a sort of, have some density. And people generally either use stainless steel scrubber, which they call wire wool, or ash, and both of them have issues associated with them. Ash, as this participant says, people talk about, coughing up black snot, black phlegm, black everything. It cannot be good for you. But using the stainless steel scrubbers or the wire wool is particularly problematic in that they degrade really quickly. And people talk about getting bits of fragments of wire wool in their teeth, inhaling bits, and I've even actually seen x-rays from a colleague of mine who chest x-rays who shows me where he can see the bits of of wire adhering in people's lungs. So people are inhaling little bits of metal in relation to the wire wool. And if you have a look at where the pipe is, you can see a fragment hanging off, and you can imagine how easy that would be to just fragment off and to be inhaled. So what are the implications for health harms? Well, apart from what I've already described, I mean, pipe scarcity is related to pipe sharing, and we can see this through the international literature. It's also reasonably common sense. If you can't get a pipe easily and somebody else has got one, you're more likely to share. And we had 44% of people reported sharing pipes in the last 28 days in our baseline survey. So this was before the intervention. I think what is interesting is that whatever your thoughts about the potential for hepatitis C transmission with pipe sharing, there is evidence of other forms of viral transmission. And this person here says, like in the crack house, if somebody came in, they had a cold sore, the cold sores would go all around the house, we'd all have them. When it was your turn on the pipe, you'd burn the pipe just trying to get the cold sore residue off. You know what I mean? I don't want to catch that, but we'll all end up with it. Like every one of us would have cold sores on the same side. And I just want to point out that what's interesting with this quote is that there's this perception that people who use crack don't really care about their health, but you can see here that this person is making an effort to try to get off, to try to prevent himself getting a cold sore, even when he might really quite want a pipe, he's going to that effort instead. I've illustrated how the use of homemade and repurposed pipes can lead to respiratory harms, but this can also lead to transitions to injecting. And we heard people talking about both the impact of respiratory harms on people's day-to-day life, impact on mobility. This person talked about having it had a very large impact on my sort of ability to breathe clearly, get out of breath walking up the road, wake up in the night, coffee up phlegm, blood, etc. But then, the implications of this is, as this other person said, a lot of people I knew did it, transition to injecting. They got to the point they're like, I don't want to cough up blood again, so I'm just going to speedball instead. As has been indicated in the previous presentations, there's a real sense of unmet need. This came up very clearly amongst people feeling that they had nowhere to go, feeling that drug treatment services were able to help them with their heroin use, but weren't able to help them with their crack cocaine use. And that also a real desperation in terms of mental health need. We asked if people felt if they needed a mental health assessment in the past 6 months. 60% yes said yes. I'm actually surprised that 43% said that they were able to get the help that they needed. But the qualitative interviews really indicate otherwise, that there was a lot of unmet need and people were very distressed. I don't want to go too much over time, but I think that this is sort of the crux actually of the presentation, and what I really want to emphasize is the real power of this intervention in increasing engagement with drug treatment services. When services gave out a pipe, they had a little monitoring report where they asked a few very basic questions. And one of these questions was, is this the first time you have ever been to any drug treatment service? Now, that's a high bar. It's the first time ever. And then they asked why. So 204 participants reported it was the first time at any drug treatment service, and 180 said the reason that they came in was for a pipe. Now, talking to providers and observations and services showed that this is really the tip of the iceberg, and actually the amount of people, the services described as new presentations were much, much higher. So the service provider says, really until the study into the pipes, there's been nothing for crack users. Since the study in the last 10 past weeks, 12 weeks now, we've had so many new sign-ups just who've never been in treatment, never accessed treatment or any services like that. Ask, has it been to do with the pipes being available? Yeah, definitely, because like I say, it was hectic. It's still hectic now, but the new sign-ups, it's unbelievable. I think we've touched about 300 new sign-ups of people that would never get to engage in services before. And their monitoring data reported 51 new contacts, whereas, quite a few providers at that service cited the 200 to 300 number mark. I'm not going to go through this, but I really want to say that somebody coming in for a pipe is not necessarily engagement, it's initial contact. But what we really saw was this initial contact led to real engagement and people disclosing quite serious health concerns, social needs that were actually able to be addressed by the service. And this little case study is of somebody who after some talking, disclosed that they were at a lot of risk for in relation to sexual health, and they also had acute physical health concerns and other concerns. And at the end, we say here, him coming in for the crack pipes led the provider arranging for sexual health testing, bloodborne virus testing, and securing a GP appointment. She gave him a ton of kit to go home with him, including the crack pipe, and invited him to visit a group session where he might be able to get help with a recent court case he needs to go to for smashing a car window. So you can see here that this first contact is actually drawing somebody in and engaging them with a range of services that they may not have been able to access before. Here's another story in which somebody was able to access eye care, and the service went and took them and got them optometry appointment, actually paid for their glasses. And what that might do for this very marginalised person and building trust is really phenomenal, actually, and important. And because of this, we have had a huge interest in the study. We've had requests from people, from services all over the UK about how they could replicate this, and we've always said it is illegal. You will have to get local police letters of comfort. And just to illustrate here on this slide, some of the places that have started to do so. So, in summary, the study is the first in the UK to pilot and evaluate crack pipe provision. It's creating an evidence base, which we hope to see will inform legislative review. And I just want to emphasise the moving stories of engagement, linkage to services reported and observed, but also impact evaluation data, which is not completely finalised, so I can't share the figures, but they're saying that we have seen reductions in injecting, reductions in sharing of pipes, reductions in homemade pipe use, and reductions of use of ash at the intervention as opposed to the control sites, and no sign of harms from the intervention. So this is really, really positive. And another thing is that people are also using the pipes for smoking heroin, and with the contamination of the drug supply of nitazines, this is a very important overdose reduction initiative as well. So that's it from me. I hope you're able to make sense of all that. Everyone's welcome to the slides.
Thanks, Magdalena. That's brilliant. Really important work there. John, if I could ask you just to turn your camera back on.
Yeah.
And we'll do a 15-minute Q&A just to cover some of the issues. John, if I can start with you, so I'll bring in one of the questions that's in the chat and I'll broaden it out a bit. So one of the questions is about injecting of cocaine, and it's about what a typical injecting daily routine would be for the average person who injects cocaine. Like, how often are they injecting? And if I could add a supplementary to that, could you elaborate from your experience what challenges that presents to delivering harm reduction services within Glasgow? And if I can add another supplementary, how do you think harm reduction services can respond within the current boundaries, taking into account what Magdalena said about the legal barriers to rolling out inhalation devices?
Right. Okay. Well, first thing, there's probably no typical number of injections per day for someone injecting cocaine, and I think we as a field have probably been quite misleading where we talk about this increased frequency of cocaine injection. I think it became apparent the longer WAND went on, then we established patterns that we hadn't really considered before, and that's people injecting, pretty much solid for 2 days, and then not injecting again for another week, and injecting again, and that kind of binge type pattern as well. So that instinctively, it causes a lot of problems in relation to someone having enough sterile injecting equipment with them for all the injections that's going to take place. In a lot of respects, it's probably not even realistic, at that point. So we have to be able to respond to that and get into more in-depth discussions about the sterility and the consequences. Maybe not so much your sharing even, but reusing your own injecting equipment, including paraphernalia. So how do we respond in a harm reduction way if we haven't yet get pipes? Well, one of the things we chose to do in Greater Glasgow and Clyde was make injecting equipment far more accessible. So over the past few years, we now have 8 residential accommodations that provide 24 hours a day, access to sterile injecting equipment. I think even as far ago as 10 years ago, that would have been seen as unachievable. People were often asked to leave, accommodations I've found with injecting equipment. Okay, and I'll finish off also by saying, we need to firm up on these harms. Just because we can't provide inhalation devices at this point, we could also be engaging with a larger piece of work to sit down with individuals, do health checks, look at the respiratory health, look at the cardiovascular health and all other aspects, and get that properly recorded, because I genuinely feel it's that data, that proper recording of the data, that's going to strengthen our case to get inhalation devices over the line.
Thanks, John. If I could move over to you, Magdalena. So there's a question in the chat about the motivations for people using cocaine. So we can maybe split that. So potentially, what are the motivations for people using cocaine instead of heroin, which would be one, because there's definitely been a shift there. And then just more broadly, what are the motivations for people using cocaine for people that maybe are opioid naive, perhaps, and I went straight into that drug. So if you could.
That's really
tackle that,
interesting.
please.
That's a very interesting question. Heroin and cocaine goes well with a depressant. So a lot of people who use powder cocaine, who may be bankers or whatever, they drink a lot of alcohol. And people who use heroin or people who are on methadone, an ideal accompanying drug is cocaine or another stimulant. It's a nice effect, gives you a high. And a lot of this population also don't drink alcohol as much. So actually on our survey, we had about 50% of people hadn't drank any alcohol in the last 28 days. If you contrast that with the general population. So, if you think about people wanting to give themselves a treat or whatever, particularly if people are on methadone or particularly if people are on Buvidal and may not be feeling that drug effect, they may want to feel a drug effect, and cocaine is going to do that very nicely. It helps to give people energy, make people more sociable, all of these things. So I think it's important to understand the benefits, the pleasures, the reasons why cocaine may want, people may feel more alert, more focused. And often being on methadone or whatever can make people feel a bit less energized. So it can be a good mix. It seems a sufficient motivation for me. In terms of why people may use cocaine who are not using opioids, well, we're seeing that all the time, aren't we? It's an increased use of cocaine in all strata of society. But this is also often accompanied by alcohol, or people using benzodiazepines at the end of the night to come down on, and things like this. So motivations for using drugs have remained consistent over the millennia. People like to change their state of their state of consciousness. People have a drink after work, etc. Yeah.
Thanks. John, anything you wanted to add to that particular question, just from a Scottish lens, if there's anything from your experience in terms of things you've encountered motivationally?
Yeah, I think people choose to use a substance, and I think the market almost determines what substance that person will use. There is no market like the cocaine market, even as a business model. It should have been finished during the COVID period, the most restricted period of time where people were behind the doors, and the market changed. It regrouped. It used social media. It used delivery, contactless payment. It tiered its cocaine, tiered its cocaine purity in relation to cost. So made sure that those that didn't have a lot of money could access cocaine. Those at the top end that were able to buy, high purity cocaine were able to do so. And they then started in Glasgow city centre producing crack cocaine, and made sure there was a good delivery network in order to get that out. But the reality is, obviously, with all drugs, we're in an era where there has never been a wider drugs available. The drugs have never been easier to get. They've never been stronger. And most importantly, they've never been cheaper. And you can put cocaine into that bracket as well.
Yes, it's fair to say the cocaine market has even evolved during that 10-year period where we've seen it really take hold amongst people who inject drugs, and there's evolvement in that in terms of the type and availability of product.
Yep.
Okay, Magdalena, I'm keen to take you up in your offer in your presentation to elaborate a bit further on pharmacotherapy. I think this has been a topic of debate for a while, because an immediate default response to drug dependence or drug problems is to medicate for it or respond with a prescription. And obviously, for cocaine, there isn't that immediate alternative, or there is some experimental work being done in other countries. So you hinted that you had some thoughts on
I
that.
do have thoughts actually. I do think it's good to have pharmacotherapies available, agonist pharmacotherapies. I mean, we've seen there's been a huge appetite for methadone and buprenorphine. It does help people. And you were talking about the need for us to be innovative and courageous. And I actually think there really is a role for agonist stimulant therapies that are currently prescribed for ADHD, dexamphetamine, methamphetamine, these sorts of things. And they are shown to work. They've been used. There's a study in Prague, or there's a site in Prague, they've been providing methylphenidate for people who are using methamphetamine. In Spain, they're providing dexamphetamine for people who are using crack, and other places. I think the issue is in relation to some of these studies in terms of their hardline outcome measures. And you could really see that in that slide you show from the Orange Book, where it said that pharmacotherapies had no proven efficacy in abstinence. If we have abstinence as an outcome measure, it's always going to fall short. And I think it's really, really important to think about how powerful it is for somebody to feel that they can regain control over their drug use. And, that things like dexamphetamine can help people. And it may not help everyone, but it can help some people, definitely. And I know people that it has helped to really reduce their use of cocaine or use of crack cocaine, and that's a first step, And so I think we need to reconfigure this emphasis on abstinence and actually think about if people can actually then regain control and use crack in the weekends or cocaine in the weekends, or wait till 8 o'clock at night before, that we shouldn't just focus on abstinence, and we need to have a good toolbox of options. And actually, we do have these prescription medications here in the UK that are currently prescribed for ADHD. There's also a lot of talk about that people may already have ADHD and be self-medicating. There are different perspectives on that, but I certainly know that some people find it helpful, and I think that we should be innovative and we should try it. I don't even think, but that's my personal perspective, and some people may not want it. So of course it just needs to be. And we asked that question in our survey, and we also asked people in the qualitative research what they think about pharmacotherapy for crack cocaine, and we have mixed response. It's really interesting, but some people really are desperate for something to help them manage their use, and I think this could work.
And if I could just ask a follow-up to that, Magdalena, I think that's really interesting. What do you think of the barriers to, because we've clearly got an at-risk population, there's a demand there, there's potentially an intervention there, there's an infrastructure of academics and health professionals working in this territory. But apart from the addiction mission funding that came out last year, there hasn't been a huge focus on it in comparison to maybe a focus there has been on other substances or other issues. Do you have any thoughts on why it hasn't progressed quicker than it has?
I mean, I don't know. I have a few thoughts. I mean, there is always the citing of the international literature and this idea that, we don't have equivocal results. But again, I'm worried about the outcome measures used. I'm concerned that this is just being used as an excuse, and different contexts are definitely going to show different things. I, I'd if I was a medical trialist, I'd be wanting to do it right now, but I would love to be involved in one. I actually just like a service to be able to do it without even a trial. We used to have dexamphetamine prescriptions for people with amphetamine dependence, for speed dependence. That there has been a tightening up of what people can prescribe. So I think, there's a sort of fear, there's regulatory issues. These are controlled drugs. Dexamphetamine is controlled drug, methamphetamine controlled drugs. There may be a fear of giving people something that may cause some pleasure, that there may be a fear of diversion. From my perspective, a pharmaceutical product that is safe, it is better for that to be diverted to somebody who may want to use a stimulant than for them to access it from a potentially toxic drug supply on black market.
Thanks. And yeah, I'm not a trial scientist either, but hugely interested in this area because I think there is potential. Okay, we'll take one final question because we will finish dead on 1:15. So there's a question, this comes up every now and again actually in other forums. So the question's about minimum unit pricing for alcohol. So the question is, do you think minimum unit pricing for alcohol has impacted on the increase in drug use, i.e. has it made drugs cheaper? Now maybe I'll take a first stab at that. I think we have the data I showed in my very first slide, the population level survey data does indicate at a general population level we are seeing an increase in drug use at a population level. I would take that as a huge pinch of salt because of the caveats attached to those general population level surveys. I don't think there is robust evidence that drug use is markedly increased across the population. Certainly not at the more kind of problematic or dependent level. I don't think we have the data for that yet. Drug use has certainly changed, I think, over the last 10 to 15 years, and the data is very strong on that. Now, that would be the answer to the first question. John's already pointed out that drugs are far more available, they're far more affordable than they've ever been, and I think that's pretty clear. The question about minimum unit pricing is also, is it driving drug death issues? Because there's a theory that because alcohol is so expensive now, people are using cheaper street alternatives like benzos or cocaine. The immediate response to that is the drug death crisis or emergency in Scotland. The onset of that predates minimum unit pricing by several years. So drug deaths were accelerating upwards quite substantially before minimum unit pricing came in 2018-19. So I don't think it's fair to say minimum unit pricing is responsible for the drug death emergency or change in drug patterns. Potentially it has a role somewhere, but I don't think anybody's been able to prove that with any degree of certainty. Perhaps they've got a role in sustaining drug deaths at being at a certain level, but certainly not responsible. So I just wanted to address that question before we finished because it does come up often, and I think it's always important to answer it because I don't think anybody has answered it enough in the evidence space, but there's certainly a role to do more there. I don't know before we finish if John or Magdalena had anything to add to that.
Yeah, I'm having a chuckle to myself here because I'm relating the minimum unit price in the alcohol to cocaine as today's topic. Now, even if the minimum price units of alcohol goes up significantly, the price of cocaine stays the same. People consume superhuman amounts of alcohol when they're consuming cocaine. They can sit for a day or two drinking without being unconscious. So, I don't think that 2 or 3 pence, per bottle of beer, or a pound per bottle of vodka is really going to make any significant difference at all in relation to cocaine.
It depends on what population you're talking about, though, John, doesn't it? And I mean, I think, I mean, I did have a concern about minimum unit pricing, particularly as I'm from New Zealand. And in New Zealand, we see people using what we methylated spirits, drinking methylated spirits. My concern always is if you place restrictions on things that are tested and have proven quality, what are people who can't afford this going to turn to? And these are often people who may have issues with dependence and may be multiply marginalised in terms of poverty and other issues, which also preclude them seeking care. So we know that when things are restricted by price, by whatever, people who may have the most problems may switch to other more cheaper alternatives. So this may potentially influence an increase in pregabalin use, benzodiazepine use. I mean, you need to stick with the depressant stimulant thing, right? Alcohol's a depressant. And people who the population who are injecting cocaine and smoking crack cocaine usually don't drink much alcohol. They're going to be using, they'll probably be on Buvidal, on methadone, or using heroin or benzos or pregabalin. So I think but that's my own personal perspective.
Okay, so I think there's certainly more to do in that area and more to study in that area, and I think there was one study done through the MISAS portfolio that looked at homeless people who drank alcohol and how they responded to minimum pricing, and I would point people towards that study, which I think you can download, I think, from the Public Health Scotland website. So on that note, I think we'll finish today's session. So thanks everybody for their participation, either as an audience member, and thanks to Magdalena and John for their time. And thanks to SDF for asking us all along. Cheers.
Thanks all.
Thanks everyone. Bye bye. Good. Bye bye.
Thank you. Bye.
Bye bye.